Welcome to part one of Target Client Factors. This is a two-part video series and it matches some of the materials that you have in your book. This provides an overview and I recommend watching the videos first and then reading the book. It might make it easier to access some of those materials or to understand them well. So I'm going to talk about in this particular video 4 major categories related to target client factors. These are client health, client repertoire, behavioral cusps, and client preference. Now, behavior analysts may arrange these differently. We may use different terms. I've tried to use terms that in many cases can be applied by professionals in other fields as well. But I want you to think about sticking with this conceptualization for now so that you can be confident you're thinking about all of these issues and not leaving any out. So first let's talk about client health. Client health includes many different factors. For example, medication. Anything that can have an effect can have a side effect, and people just don't think about this often enough. This is equally true with things that are non-prescription medications, over-the-counter medications, holistic medicines that people are using, essential oils, whatever it may be. If it can have an effect, it can have a side effect. And so you want to take into consideration what medications a client is on and what side effects they may have. Because, for example, you may have a client who's on medication and sometimes they take the medication and sometimes they don't take the medication. And whether they're on the medication or they're not on the medication, the function of behavior changes. There is literature supporting this. And so understanding medications is a really important thing in terms of picking the right treatment at the right time. In other cases, you might not need a behavioral intervention at all if they are on medications. And so sometimes it's a matter of getting somebody the medical treatment that they actually need, and once that's addressed, they may not need a complex behavioral intervention. Anyway, in addition to medication, we should be thinking about medication conditions or comorbidity. So a lot of our clients, in addition to being on medications, also have additional medical conditions or comorbidities. There are conditions that tell you immediately that there are some treatments you shouldn't use. So for example, if I'm working with a client that's really obese, it immediately tells me that I should not be using restraint, that it places such a greater risk for a serious injury or death for clients who are obese that it should be avoided, absolutely. Now, of course, I could go on all day about reasons we should avoid using restraint and using it only under the most circumscribed conditions, but you have to be aware that there are medical conditions that influence whether or not you should be using forms of restraint. What else about medical conditions or comorbidity? There are times where I've seen people put complex behavioral interventions into place. It takes a lot of resources. It takes a lot of time. It's exhausting for the people who are implementing it. And as it turned out, if the client had had proper medical care sooner, that complex intervention could have been avoided altogether. Let me give you an example. Seizures. Some people with seizures experience what's called seizure-induced aggression. Right at the onset of a seizure, they become aggressive. And as you can imagine, aggressive behavior is something that we get referrals on all the time. The approach that we're most likely to take is to do a functional analysis or a functional behavioral assessment to identify the function of behavior and to develop an intervention to put into place. Well, as it turns out for these people, that the reason that they're being aggressive is directly connected to the seizure, and if they were on proper medication, this wouldn't be happening. I can tell you in my career, which has been over 25 years, I have identified many people who were having seizures and no one knew it. And so I referred them to their physicians who often referred to neurologists to do evaluations, and many of these kids were in fact having seizures. Sometimes somebody just thought they looked like they were spacing out and they were actually having absent seizures. Anyway, it's something that you want to make sure that you understand common comorbidities for the population you're serving. My specialization for over 25 years has been autism spectrum disorders, and so I know seizures are a common comorbid disorder, and it's something that I keep an eye out for. Anyway, what else? Another client health issue you want to think of more generally is just biological issues. And often we're going to connect this to motivating operations. There are a lot of biological variables that are going to influence behavior. Because these biological variables can impact behavior directly and indirectly, it's easy to start connecting this to the motivating operation literature. If this connection isn't immediately obvious to you, read about motivating operations. It's something you're going to want to master before you take the BCBA exam anyway, and then connect with your instructor if you've got questions. But let me give you an example now. There are a lot of people who don't get enough food to eat in this world. And so they might be what's called food insecure, meaning that they can't count on eating food on a regular basis. Even if they're not hungry right now, this can influence their behavior. And so addressing issues of systematic hunger is a really important issue when you're developing interventions. I might have a client who the value of reinforcers is altered. For example, if I don't have a lot of energy because I'm hungry and I'm pretty chronically hungry, then giving me the reinforcer of running around and playing is probably not going to be very valuable to me. So something that I thought, oh, well, that seemed to work last week, but it doesn't seem to work this week, could be directly related to how much food that they've had recently. Think about biological variables like hunger, stamina, sleep deprivation in relationship to treatment selection. Sometimes the intervention you develop is inappropriate with this in mind. So, for example, I'm going to combine a couple of different factors we've talked about here. I might have a client with an autism spectrum disorder and cerebral palsy, and someone has prescribed 40 hours a week of early intensive behavioral intervention. But the truth is that this client does not have the physical stamina, the capacity to sit in a chair and engage in therapy. The act of sitting up, reaching out, manipulating variables, well, they don't have the stamina to do it. And so this might not be the right treatment. It might be that the treatment is fine, but the dosage is not. So in other cases, other interventions might be necessary. So I might need to be working with a physical therapist. And if by working with a physical therapist and having some hours with physical therapy, I can increase stamina, now I've increased the likelihood that they can get a dosage that's closer to what this particular client needs. I'm not saying all clients need 40 hours, by the way. I'm just using that as one example. Now, final client health issue, and we really could cover this under medical conditions or comorbid conditions. I break it out separately because I think people overlook this all too often in our culture and in behavior analysis in general. This topic is mental health issues as a form of comorbidity. A lot of people on the autism spectrum have mental health comorbid conditions. So, for example, a lot of our clients, well, a lot of people in society in general right now have anxiety disorders. A lot of our clients have comorbid anxiety disorders. If I have a client on the autism spectrum who has social skill deficits, one of the options I might consider is a group social skills program. If I have a client with a comorbid anxiety disorder, I'm much less likely to say this is going to be my perfect solution or my ideal treatment than a client that does not have a comorbid anxiety disorder. Why? Because being in that group format may be a condition that elicits anxiety. Okay, what else related to mental health? Sadly, individuals with disabilities are at a much higher rate for abuse than the general population. Girls are at an even higher risk than boys. The vast majority of girls with disabilities are abused in some form or another by the time that they're 18 years old. About 2/3 is what the estimate is based on the best available literature. Some abuse comes at the hand of caretakers. Others experience bullying or dating violence, and you need to be considering this as you're selecting treatment. So, given how prevalent abuse is, you should always consider this possibility before selecting a treatment. For example, this might influence again if I want someone to be in a group setting if they have a history of being bullied. If I'm wanting, why would I pick a peer-mediated intervention if that is, if the people who are peers are similar to or the same people that have engaged in bullying in the past? Other examples might include what level of prompting I use in my intervention. A lot of people use physical prompts with people with disabilities all the time. Well, given that so many of them have experienced some form of abuse or not, I think we need to take a look at when it's appropriate and when it's not. And if we're seeing huge reactions from our clients, we might want to start guessing that a physical prompt may not be ideal for some of these clients. Another comorbid condition I want to talk about quickly before we move on is substance abuse. Substance abuse is a comorbid condition that we should be actively considering as behavior analysts. A lot of our clients have mental health issues and they self-medicate with either alcohol or illegal drugs. As you can imagine, identifying the function of behavior is probably not going to be your top priority when you have clients who are abusing substances, including prescription drugs. And so you need to be looking for these comorbid conditions before you begin selecting other treatments in some cases. All right, so that's the highlight of client health that I wanted to cover. Let's talk about client repertoire, and I think this one will come very easily to you. We often think about what skill we should work on based on what skills the client has right now. That jumps out at us right away. If I'm working on a skill, they need to have other prerequisite skills before they could master this one. How does that relate to selecting an intervention? Well, I know I've given this example before, but it's the most obvious and easiest one to give. If I have a client who can't pay attention to a video modeling is not the right treatment. I get so frustrated hearing people say that people on the autism spectrum disorder are visual learners. This is the exaggeration of visual learning in individuals with autism spectrum disorders is really a very significant problem. I've seen so many clients who were sat down in front of a video for video modeling, and the client didn't have the capability of attending to the video, much less attending to what are relevant variables associated with that video. What were the skills that were demonstrated? What were the consequences that were delivered? And so, again, I break this down more in the book, but you do need to be thinking about what skills does the client have before you select any treatment. So don't just use video modeling as one example. Think about every treatment you might use and what are the prerequisite skills your client should have before that treatment can reasonably be effective. Next, I want to talk about behavioral cusps. This is a hard one. A lot of behavior analysts I know haven't really thought through the issue of behavioral cusp related to treatment selection. Often we think about a behavioral cusp in relationship to a skill that we want to pick, not the treatment itself. Before I go on, I want to remind you, we have another video on behavioral cusps. My recommendation is that you watch that and that you understand behavioral cusps before you watch the rest of this video. I know that some of you just won't listen. I recommend that you stop the video at about 13:25, which is where we're at now, and say, okay, I'm going to go watch another video and then come back to this one again. For those of you that feel like you have to push through, as a brief reminder, a behavioral cusp represents a change in behavior that has really far-reaching effects because they significantly alter the client's access to new environments, which includes new contingencies. I do want to point out that most people forget that a behavioral cusp can lead to a positive outcome or a negative outcome. So, for example, learning to ride the bus can have a positive outcome. You can take the bus so that you can go get a job, or it can have a negative outcome. You can take the bus to go buy some illegal drugs. Anyway, so how does this relate to selecting a treatment? Sometimes, not always, sometimes, you can pick a treatment that can lead to a behavioral cusp. And let me give you my favorite example. I've worked with kids with autism spectrum disorders for a long time. Many people select using visual schedules for their clients, and there's evidence to support using visual schedules. I'm not opposed to it. However, using a visual schedule doesn't necessarily lead to independence. And so if I see a client that has a visual schedule, I'm likely to move them from a visual schedule into a self-management system. Think about how much being able to use a self-management system and being independent opens new doors for you, gives you new opportunities, gives you access to new reinforcers. And so sometimes picking the treatment itself can lead to a behavioral cusp. If you've got questions about that, please contact your instructor. I think it's a tough concept, and if you need to talk it through with somebody, your instructor should be able to help. All right, last one I want to talk about here in terms of target client variables. So for this video, we've got one more, is preferences. Preferences generally fall into multiple categories. First of all, preference assessment. Most of you have learned about preference assessment and have done preference assessments before. Awesome. Just don't think this is the only way to incorporate client preferences. If you're not familiar with preference assessments, there are a lot of different techniques that are appropriate with different clients, so make sure you become familiar with that literature. Your instructor can help push you in the right direction if you need more help. Other than preference assessment, what else is there? Choice. There's so many ways to incorporate choice into treatment selection. Even the youngest kids with disabilities do better when we offer them choice. And really, isn't this something that we should be offering to all human beings? More choice. You can simply ask a client with stronger communication skills which of two interventions they prefer. You can explain to them what it's like. You don't have to, but why wouldn't you give them an option and see if the one that they prefer is the one that is effective? You can also be and should also be measuring their reaction to interventions. We'll get into this more later in the book and later in the semester. I would also recommend checking out the work of Layer and colleagues in 2008, as well as numerous other publications that are related to concurrent chain arrangements. And this is going to give you a lot more information about choice. Make sure you're familiar with this literature. Again, reach out to your instructor if you're not sure about these. A last area related client preference I want to bring up is selecting treatments where preference is a natural byproduct. So for example, things like contingency contracts, you write the contract and you develop that contract with the client and you work with them to identify what the reinforcer is. Another example would be a token economy. A token economy, they get a certain number of tokens, they get to trade it in for something. How about they get to pick what they get to trade the tokens in for? Now, some clients are not as high functioning, and there are even options there. For example, look at the environmental enrichment literature. And not that you have to create an enriched environment 100% of the day, but for at least part of the day, if you have an environment that is enriched, meaning that you've arranged the settings so that there are lots of materials that the client is likely to manipulate or use in an appropriate way. By the way, this has been used to reduce stereotypic behavior for some research participants. Then why wouldn't you want to use that? Again, they're getting access to something that's preferred if they have a choice between a bunch of different stimuli and they get to pick which one they do. I will remind you, to be effective, you sometimes need to combine environmental enrichment with other treatments like response cost. But even when you do, because they have so much access to these preferred stimuli, you're still incorporating choice, which is a method of preference in the intervention. So those are the things we need to talk about for this first video. We're going to talk about more topics related to target client factors in the second video. But I hope that already you can see that there are a lot of factors relating to target client factors that you should be thinking about and incorporating in treatment selection. It's not just looking at a list that somebody says is the best evidence that these are good treatments, these are effective. You also have to incorporate these components to pick the right treatment for your client.